Welcome to the Well Rooted podcast. In today's episode, we are joined by Robbie Williams, an expert oral surgeon specializing in dental implants. He'll be sharing insights into the world of implants and answering some of your most common questions. A brief introduction about Robbie. Robbie qualified from Newcastle University in 2012 with merit in both clinical and academic dentistry. He has extensive experience working in oral and maxillofacial surgery and oral surgery units in hospitals. Robbie has completed multiple postgraduate qualifications and he now lectures and mentors colleagues undertaking postgraduate training in the hospital. He has a master's degree with distinction in dental implantology and has recently passed the prestigious Tricollegiate membership in oral surgery examinations and was elected as a member oral surgeon at the Royal College of Surgeons of Edinburgh. Hello, Robbie, and thank you for joining us for this podcast. How are we doing today?
Very well, Pradeep. Thank you. Thank you for inviting me. It's a pleasure.
You're more than welcome. So the idea of this podcast is to help our fellow colleagues, some mostly general dentists, to understand a little bit more about implants because that's what you're into. I refer most of my cases to you and I get really good results. So thank you for doing all that lovely work. So just to share the knowledge, we're going to ask you some questions based on implants really, and people can listen in and benefit from it. So I'm going to start off with some really basic questions, Robbie. What made you become a dentist in the first place?
Yeah, a great question, which I've been asked a lot, mostly by patients who can't fathom why on earth we do this job. But I think for me, I was always good with my hands kind of technically. I always enjoyed playing with Meccano and things like that when I was growing up. My brother's a mechanic and he's about 5 or 6 years older than me. So I always was helping him out, fixing cars up and that kind of stuff. So I loved working with my hands. My dad was a dentist. He's retired now. So I suppose that kind of planted that seed in my head. But he was never pushing me to pursue it. And even actually when I turned around and said that that's what I wanted to do, he kind of looked at me and said, "Are you sure? You're not just doing this because, you've seen me do it." And it gave me the perfect combination really of those technical skills. I was always interested in science and those kind of things. And I suppose the cheesy line of having the opportunity to help people, genuinely was a part of it. So for me, it combined all the best elements. I did think about being a medical surgeon for a while. But then when I looked at the training pathway and how long that took, it made more sense to me to go down the kind of dentist route. And I suppose before I even started dentistry, surgery I was always fascinated by, and so it's no coincidence I've become an oral surgeon. And funnily enough, my next door neighbour was a rep for an implant company at the time, and so she was showing me these models. She said, "You've got to get into this. These are because they were fairly, new at the time. You've got to get into this. These implants are going to be the future of dentistry." And I was fascinated by the fact you can put a bolt in someone's mouth and put a tooth on it, and so it was that kind of sparked my interest really.
Brilliant. So at the back of that, you said you saw some implants on a model or something. So can I ask you what particular system do you use and why do you use that particular system?
Yeah, currently I would say probably 99% of what I do is Straumann implants. I've used several different implant systems over the years and tried different types of connection because I don't know how many people know about it, but the implant obviously has an external thread around the outside that are different aggressiveness, and that dictates your stability in the bone and how, a bit like a screw in wood, how easy or difficult it is to insert and how much grip it gets on the outside. But they also have obviously the internal connection in which the crown or the bridge or whatever you're connecting in connects into, and they can vary. And there's no need to go into the technicalities, but while all implants these days probably work, they all have little differences that make the workflow and the way in which the kind of teeth emerge from the implants, it varies, and how the bone behaves around them. There is a lot in it that you need to understand about implant design, and that's why I've tried lots of different manufacturers over the years, different connection types to see how they feel, how they work, even to the degree of how comfortable it is for the patient at that restorative stage when the implant's in and it's healed, but we're taking the impressions and I'm removing components and putting them in to take impressions. How comfortable is that for the patient? Because if I need to numb them up every time I do that, that's a big deal for me, because I want to reduce the number of times I'm having to give local anaesthetic for the patients because they hate it. And so, yeah, Straumann, the system that I use, is the premium implant brand. It's Swiss made, and that's, again, I'm a bit of a geek in terms of how things work and how they feel in my hands, the nuts and bolts of it. They're so precise, they are so predictable in how they perform. The screwdrivers fit every time and they don't fall off. I've had that with systems where the components fall off because the fit isn't very precisely milled. It's comfortable for the patients when I'm restoring, and it's predictable, and they've got a very long track record.
Amazing. The next question is, suppose someone is going through a phase where they've seen this tooth, they've diagnosed it as being not treatable, it's a poor prognosis tooth, and then they obviously have the discussion with the patient, well, this needs to be extracted now. And then your options for replacing are denture, implant, bridge, or leave the gap. And then the patient then decides, well, I like the concept of that implant. And then the patient has already made that choice that you're going to have this tooth taken out and they're going to have an implant there. So when the root is still there, at what point is best to refer the patient? I mean, should we take out the root and then do a referral, or preempt that this tooth needs to come out and send it to the person who's doing the implants after the extraction?
Yeah, it's a great question. I suppose if the patient's in pain and there's no way of addressing the pain without removing the tooth, or there's spreading infection or something like that, if there's a reason to take the tooth out that you would do that there and then I would still proceed with that. I wouldn't delay that and cause pain or problems or risks for leaving the tooth in. However, if it is asymptomatic or it's a chronic lesion that is not acutely flared, then I would always leave the tooth in and send it to the implant dentist at that point with the tooth in. And there's a couple of reasons for that. And this is obviously my preference, but from my point of view, my reasoning behind that is, firstly, when possible, I like to take the tooth out myself, because it gives me an opportunity to see what the bone is like at that stage before I've taken my CBCT scan. And so I can extract the tooth, clean the socket out, and have an idea of what I'm going to be facing, in a couple of months' time when I go back in. So it gives me a bit of an insight. It also is an opportunity for me to build that little bit of trust with the patient, because when, they might be your long-standing patient, they've only just met me and they've had a consultation and then we're straight into treatment. So if I have an opportunity to deliver normally what's fairly straightforward, episode of care where I take the tooth out, it goes a lot better than they expect, hopefully most of the time. It's quite a positive experience, so they're much less nervous when they come to then have the implant placed. The second reason I'd like to take the tooth out is that debridement of the socket, in my opinion, is a massive factor in how predictable the next stage becomes, assuming we're staging. So cleaning out beneath the root once it's been removed, even on a tooth that you don't think's infected, is really very important from my point of view, but particularly if you've got one of those chronic lesions of granulation tissue, that apical radiolucency around a tooth or a root. Simply removing the hard tissue, removing the root is not enough. You need to get right in that socket and thoroughly manually debride it so it's clean, to get rid of that granulation tissue. It's likely the body will heal in time if you were to leave that there and it would remodel, but number one, it takes a lot longer. So if I want to go back in a couple of months' time, it probably won't have healed very well because that's still there. But it can get walled off and actually remain as granulation tissue, and you don't get good bone healing there, which clearly, if I'm going to go and do an implant, it's a big deal for me. So yeah, they're the main reasons why I like to take the tooth out. The next reason why I'd like the opportunity to have the tooth still there from the start with me is that more and more these days I'm doing immediate implant placements. So if the situation is favourable and the clinical conditions are correct, I will try when I can to take the tooth out and place the implant on the same visit. It doesn't necessarily always have to have a tooth connected on at that point. We don't have to load the implant, but I'm finding more and more, and actually I think there's a general trend in implant dentistry that people are moving more towards immediacy, because there are a lot of positive indications for that. And while in the past it was probably riskier, I think with modern techniques and modern protocols and modern implants, it's a much more predictable procedure. And for the patients, it's fantastic because we take the tooth out. Most of the time, I don't even need to raise a flap, so I don't cut the gum, I don't pick up a knife. We clean the socket out. There's very little drilling because there's already a socket there. We just need to drill a small amount of bone to gain stability. The implant gets placed through the same hole, and sometimes there's not even a suture placed depending on how it goes. And the post-operative discomfort for the patients is extremely minimal. It's all done in one visit, one set of local anaesthetic. There's loads of positives about it, and that's not even including the positives that we get, especially at the front of the mouth, where if we're going to put a temporary tooth on, we can preserve those soft tissue structures. If we take a tooth out and we can put a temporary tooth on that mimics it exactly, it maintains that soft tissue support, and that's how we get these beautiful results where it looks, literally on day one like nothing's happened almost.
Right. So suppose you do decide to have an implant there, and then the patient needs a bone graft. Can you talk a little bit about bone grafting? What types are there? Is one particularly better than the other? And I've seen people who don't like animal bone within them, and then what choices do they have? So just a little bit about bone grafts, if I may, please.
Yeah, of course, no problem. Bone grafting, I have this conversation with every patient actually when at my first consultation, because I feel it's important they should know what's going in their body, and they should have a preference as to whether or not they want certain materials. And I kind of break it down into 4 materials really. One is their own bone. That is gold standard, undoubtedly. It's got morphogenic proteins in that make it heal quicker. It's the only osteogenic material that we have for bone grafting that actually stimulates bone growth. The others are kind of conductive and that kind of thing, but it's the gold dust. The big downside, of course, is we have to harvest it from somewhere. So, we can collect a small amount off the drills when we're drilling the implant site, but it's minimal, and in some cases there's not enough there. Otherwise, we have to either raise a much larger flap and scrape nearby, which is not a particularly pleasant experience for the patient, or we're harvesting from sometimes sort of wisdom tooth area at the ramus of the mandible to collect scrapings. But again, if they're not under sedation, it's just local anaesthetic. Patients tolerate it fine, to be fair, but it's not a very pleasant experience for them. And to harvest enough, if you're doing a big graft, it's quite a lot. So that's gold standard. But in the majority of cases, it's probably not that necessary, I would say. Next up, we've got synthetic grafts, which are man-made materials that you kind of mix with water and set like a cement in the mouth. I use them a fair amount. They're great in small defects that are well contained. I always kind of give the analogy of if you had a bucket to fill up and it had 4 walls on it and you just needed a material to fill the space, they work perfectly. But as soon as you lose one side of the bucket and you need that space maintenance from the material you're using, the synthetics don't work quite as well in those kind of areas. And then the last 2 is cow bone, like you've said, or animal bone. It can be porcine. But animal products, which are xenografts, and then you've got allografts, which are human bone. So again, there's 2 or 3 different, multiple different products on the market now, allograft materials, some from cadaveric material, some from live donors, from hip replacements, and they take away the live bone and harvest it. That is, for me, the second best, I suppose, if I was to have a preference for how it behaves in the body and how it turns over and is replaced by natural bone. But the downside of that is some people don't like the idea of having another person's bone in their body. Yeah. And also in the UK at the moment, the organ donation guidelines say that you can't if you have human donor bone used on you, you can't then donate blood or organs to somebody else afterwards, which I don't think a lot of people know. So that, for some people, clearly is a big deal.
So what is the reasoning behind it? Once you get an animal bone graft, why is it that you can't?
The animal bone is okay,
yeah.
But the human bone, I haven't had an answer from them as to why, because I've contacted them to ask about this and to clarify. I assume it's because it's a donated product from another human onto you, therefore they're worried, I suppose, about risks. Although every patient is screened that donates, and there's not yet been a case of any disease transmission between people by using these donated products. I mean, it just comes it looks like salt granules in a packet. You can't even tell it's human bone anymore. It's so sort of carefully processed. But yeah, that's it. I personally think it's a massive shame. I also think there's probably hundreds, if not thousands, of people walking around who've had it and not even known about it, and probably are donating blood and organs anyway.
Yeah.
But I think I know about that, so I have to tell my patients about it, that kind of duty of candour. But that's a deal breaker for quite a few patients, and it's a bit of a shame. And I hope that they review it, because I think safety-wise, surely a small amount of this product is not going to make. It's a shame to then waste their whole ability to donate blood and organs.
So a little bit about socket augmentation. So when I've seen this where general dentists are encouraged to, once they've had a tooth taken out, they should say, they normally say, well, could you place something in there to hold the volume of the bone, or so that it sort of acts like a scaffolding. How true is that, and is that a useful procedure to do, socket augmentation?
Yeah, absolutely. So yeah, ridge preservation or socket augmentation or socket grafting, however people call it differently, definitely does work when it's done well, and definitely has its place 100%. I think it partly depends on the implant surgeon's preference and how they like to do it. I know a lot of people who do this very routinely because they like the idea of take the tooth out, clean it, bone graft, you leave it for 4 or 5 or 6 months depending on the product, and then when you come back it's very straightforward because you've got a perfectly healed ridge, loads of bone, and the second stage is super simple. The big downside, of course, then is you've had to wait that 5 or 6 months before you can place your implant, and then there's another 3 months before you restore it, so it adds quite a lot of time to the patient's journey. And during that time they may have a gap or a partial or some kind of temporary that is not that satisfactory for them. In my practice, I've already said my go-to when I can and I see a patient is, can I do this as an immediate, because that's the quickest and simplest and best for the patient. Often that's not possible for multiple reasons, so okay, my next choice is, can I go in early? And what I mean by early is normally within 2 or 3 months. So my kind of standard protocol would be, if I take a tooth out and I can't do an immediate, is I would come back probably in 2 to 3 months and place the implant at that stage. By then we've had complete soft tissue healing and partial bone healing, so not complete bone healing, but enough to hopefully get stability on your implant. And it means that then my standard, probably 80 to 90% of the workflow that I do is that kind of protocol where the patient is finished from the moment we take the tooth out to them having a tooth back in is about 5 months. So that's the time I'd normally have to wait before I can even place the implant if you've socket grafted. Where socket graft has a place in my practice is in situations where the patient needs maybe some time to save financially, but the tooth is causing symptoms or is damaging the bone, and I want to stop that process. So then we'll take the tooth out. They say, look, I need 6, 12 months, however long to, I want to do this, but I need some time. Or let's say they were going on a big trip somewhere, traveling, and they're going to be away for 5 or 6 months anyway. Then great, put the bone graft in, preserve everything, and when we come back, it'll be hopefully nice and easy. And then the other situation is where I use it quite a lot in maxillary molars, where we've got very limited bone height already. And I know that there's not going to be enough bone for me to place an implant either immediately or let's say within a couple of months, and I want to wait for complete healing. But if I did that without bone grafting, there's a risk I will lose even more height because the sinus might pneumatize if I waited 5 or 6 months, and obviously we definitely lose width horizontally. So take the tooth out, debride and clean it, and then bone graft the socket, and that maintains the bone that we've got there. There still might not be enough when I go back, but at least I know I have maximised what is there, and any I need to add is reduced.
A little bit about occlusion in implants. Now, all of us are aware that the implant doesn't have PBL around it. So we've heard a lot of things, and the occlusion is quite critical. You need to manage it really well. So if you can just give us some tips on how to manage, or how do you manage the occlusion in implants? What are some of the things that the general dentist should know once an implant has been done? Should they be checking for anything on a regular basis?
Yeah, absolutely. And I'm really pleased you're bringing this up, actually, because for me it's, as a dentist who works off referrals from others, I often see my patients and I'll review them after a year and check everything again, but then I kind of discharge them because I can't just keep reviewing every patient every year. And so it's a little bit of a worry for me over time, like you just said, in terms of how are the implants being monitored and looked after then, and the crowns being monitored. the occlusion is definitely something that should be being checked at general checkups with implants, and certainly I'd say at least once a year. And the reason is that you've just mentioned it, they don't have a PDL, and so we need to be careful about how they fit into the patient's occlusion. And this is particularly important in patients with parafunction, clenching or grinding habits, because there is no give, or as I say to the patients, this tooth has got no suspension. You know, if you clench or grind on your natural teeth, you get that little bit of flex, there's that little bit of give. If your implant is in the way, there is no give, and so the only thing that will give is it will either chip and fracture, or you will get screw loosening. You could, worst case scenario, get implant fracture or bone loss around the implant. So it's definitely something that needs monitoring in the long term, particularly as most implant crowns I do these days are zirconia, which is an extremely hard material with very little wear. And so over time, their adjacent teeth may wear or will wear inevitably over 5, 10, 15 years, but the implant won't. And so while on day one the implant occlusion may have been perfect, 10 years down the line that could be a very different situation. And so I always stress, and I write it in my discharge letters, as you've probably noticed, that I would recommend checking the occlusion and monitoring that over time. Now, what is it that we're looking for? Honestly, if I'm just talking about a single tooth restoration now, a single crown somewhere, 4, 5, 6 region, in light ICP, just gently holding their teeth together in light contact, so no clenching, you should be able to get, I use a piece of shim stock and folded in half. I can't remember how many microns that is. Is it like 30 microns? I used to know.
Eight
microns. Is it, all right. Is that folded over doubled?
Then it's 16, isn't it?
16. So I use a double thickness of shim stock basically between the teeth, and in light contact, I should be able to pull it through on the implant crown, but obviously gets held by natural teeth. In clench, if it's perfect, you should then just catch the shim stock so it holds. So essentially that is accounting for the PDL adapting on the adjacent teeth, because in light contact the PDL is not under compression, so the implant crown shouldn't be in contact at that point. When the PDL on the adjacent teeth is loaded in clenching, it should then contact, and that's the perfect occlusion if you can get it. It's difficult to achieve. If you've got healthy adjacent teeth that are, happy and able to share and take the load, then I'd probably err on the side of caution and have it lighter rather than heavier. But if that's what we're aiming for, and obviously you can use articulating paper to mark up where to adjust and that kind of thing. Lateral excursions, I try and avoid implants being involved in lateral excursions wherever I can, or have them very light, particularly where we've got decent teeth nearby that can do it for us. If I'm restoring a canine, for example, and the patient was previously in canine guidance, I try and move them into group function when I design my definitive restoration, and again, just to share the load. But if I know that I'm going to have to rely on my implants for, guidance, then I will choose wider implants. And again, that's why one of the reasons why I use Straumann is their implant alloy, rock solid, is the strongest implant material in the world. And so my worries about that fracturing or managing in those kind of stressed situations is better. But it's something that you really need to be careful of. And one more thing about occlusion before I forget. PDL is not just about giving suspension and shock absorption, it also gives proprioception. And so implant teeth don't have anywhere near the proprioception that normal teeth do. So the patient may not be aware of the forces they're putting through implants compared to natural teeth, which is not so important on a single crown because they've got teeth nearby that will tell them how hard they're biting. But on a full arch of implants, we need to be really very careful about how patients are biting and what kind of forces they're putting through their implant bridges, because they won't have a clue how much force they're putting on that, and that's something they need to know about as well as us.
Brilliant. Thank you. That was really useful, Robbie. Much appreciated. At the back of that question, we've seen, well, I've seen, suppose an upper right one has been, he's had an implant, and the patient was young, maybe early 30s or something like that, and after 20 years or something, you see that the teeth alongside have worn down, and there's been some super eruption of the teeth such that the gingival margin of the implant is way higher now as compared to the neighboring teeth. And some people have got high lip lines, and that kind of that it looks a lot taller. And so, I mean, is there a way around it, or you just need to, accept the way it is, or can something be done with it?
Yeah. One of the this is the main problem. Exactly what you've just described is the main problem in placing implants in patients too young. So it can happen, as you've described, potentially because of wear on adjacent teeth and then compensation with them, over erupting. Although I think that's very minimal. Most patients don't wear their teeth to such a degree that gingival margins will become imbalanced unless they've got a real parafunctional problem. But the main problem with what you've described, and the main way that happens, is that patients have continued skeletal growth. And so if you put an implant in an 18-year-old or even a 20, 21-year-old, we don't know if they've finished skeletal growth yet, and particularly in the jaws, and because they're one of the last bones to kind of finish growing. The problem is if we place an implant in the perfect position, and I've seen this at lectures nationally and internationally where they look incredible. It's a perfect job when the patient is 18, it's just finished, and then they show a photograph 5 years down the line and it looks horrendous, because exactly as you've just said, the implant stays exactly where it is, and we don't really know why this happens, but it does, and all of the teeth continue to grow past it. So in those scenarios, the incisal level also moves up, as well as the gingival zenith. The implant literally stays fixed in space and everything moves around it, and it's extremely unsightly, and it looks awful. And you can change the implant crown to correct the incisal level because you can make a longer tooth, but that gingival margin is almost impossible to fix, because the bone level, which dictates where the soft tissue is going to lie, has stayed there, and bar explanting the implant and regrafting and doing this massive job, you can't predictably recover that, which is extremely challenging. And so that's why for me, I will delay implant placement in patients who are young as long as I can. Really do. Even like people in their early 20s, I'll see if they'll manage an RBB for 5 or 10 years, because I'm just terrified that I'm going to get caught out with one of these cases. You can do, some people, if they're lucky or they've got, excellent clinicians, might be able to retrieve it a little bit with soft tissue grafting techniques and clever things like that, and contouring the subgingival profile of the crown to try and encourage downgrowth of the soft tissues. And you can probably manage small discrepancies like that, but it's not simple.
So, Robbie, tell us, what are some of the complications around implants? When do they fail, and why do they fail, and what can be done to prevent failure? Of course, I mean, as a general dentist, I can think of it's not being maintained around it. This perio disease, there's loads of bacteria around it, and that's why implants fail. But apart from the hygiene, is there anything else that the general dentist should look out? Is the implant failing, or what are the signs of an implant failing, and what should they do about it?
Yeah. I suppose failure can be broken down into two aspects. Obviously, there's the mechanical failure where it's loosening or the crown is debonding off the abutment, and so things are coming loose regularly, or screw loosening, and that's a sign of something not being right. Normally it's the occlusion. And so that's, if you get repeat loosening of screws and crowns, there's probably something not quite right with the bite. Certainly component fracture is extremely uncommon, particularly with the systems. I use Straumann because it's so well engineered and such strong connections and materials. And then you've got obviously failure from a point of progressive bone loss, and ultimately then implant exfoliation if you leave it long enough. And that is, it's one of two reasons really. One is patient factors, so they're either genetically predisposed to it, so history of periodontal disease, or just biologically, for whatever reason, their body won't maintain the bone around the implant despite their best efforts and having excellent oral hygiene and coming every few months for cleans. And the other reason then is probably that it wasn't done that well in the first place. So implant in the wrong position, three-dimensionally, possibly too buccally, or maybe there wasn't ever enough buccal bone there in the first place and it's receded, and now we've got no bone and it's just soft tissue, which is much more susceptible to breakdown and problems. Or it might be a cemented restoration and there is some cement been pushed subgingivally, and that's a chronic nidus for inflammation and periimplantitis. It's one of the big causes of periimplantitis, and I don't cement. I wouldn't say any, but I don't remember the last time I cemented an implant crown. It used to be very much in vogue, and a lot of dentists maybe still do it, but I screw retain 99.99% of what I do now for that reason, because I'm not confident enough that I won't get cement under the tissues, and screwing them in removes that risk. And yeah, they're the main factors really, I think, or possibly not placing the implant deep enough, not giving enough of a smooth emergence. So you have this kind of lollipop stick, they call it, where you have the implant and then the crown just comes out and there's this massive molar on a really skinny implant with not a smooth emergence, and it's uncleansable. There's probably going to be some pressure on the bone peripherally and not enough of a contour to allow bone peaks to remain and be established. So there's lots of ways in which we're guilty as the implant dentists for creating an environment that was destined to fail. And the problem is, at 1 year you don't know that, because at 1 year it can still look pretty good. It's only 5-10 years down the line that these things start to become apparent.
Which leads to my next question, Robbie. So the question is based around the restorative aspect, so restoratively driven implants. So I've come across this in the past as well, where there's been a case where the implant has been placed by the implant surgeon, and then the general dentist is trying to put the crown on it, but then the angulation isn't very favorable. Any advice around that? What can be done? How can it be prevented if it does occur? What to do about it?
Yeah, again, I think everyone has a bad day. I've had bad days, and the implant doesn't end up quite where we expect it to be, which is why I'm using guided more and more these days, because that reduces the number of bad days that you have. But ultimately, it's the biggest part of implant dentistry success is in the planning, and it has to be restoratively driven, and that's coming from an oral surgeon. So that was the first thing that I was taught, and my mentors have hammered home to me, and it's what I hammer home to everybody that I now mentor, is when I get my CBCT scan, literally the first thing I do on every case is put a mock tooth in there. Just a little, on the software, there's an ability to put a rough mock-up of a tooth, central incisor or an upper six. It doesn't have to be anatomically perfect, but approximately the right dimensions, because that sets my restorative envelope. And then that is the first thing I do, because there is no point me putting an implant in a position where there looks like there's decent bone, and then finding that my screw access is coming out the buccal or out the incisal edge. So I start with the tooth, and then I put the implant in the perfect position to the tooth, so 3 to 4 millimeters beneath my planned gingival zenith. And then the last thing is I see, all right, well, what's my bone like in that position? So it's kind of backwards from how you think it would be done. You'd think you'd put your implant perfectly where you want it and then see how it looks with the tooth. That's how you end up with problems. Almost always there's an ability to rebuild the bone. And if there's not enough bone in that situation, then you might even choose to do the bone grafting first and then come back to it in 6 months, because I think that's how important restoratively driven treatment planning is. There are, of course, ways around it, and when you understand what you're doing, you can place your implant at an angle on purpose, but you will choose to use what's called an angled abutment. So you might use an angled screw channel. So previously, if you, like you've just described, where you're trying to restore, for example, a central incisor, because if the patient's got quite a proclined maxilla and the sort of incisal edges are off, and your straight line access from your implant means that your screw channel would come through the incisal tip. In the old days, you'd have to cement that, because it's the only way you can stop having a hole in the middle of your central incisor. But these days, we can correct up to 20 degrees with an angled screwdriver. So you can still screw retain, still engage the best bone, but you can have your palatal screw access hole, because the screwdriver will allow for 20 degrees in deviation. So there's lots of little ways that you can bend the rules, but again, it's planned. I think the main issues come where mistakes are made, and even just little things like we're talking about angulation and screw channels, but I think a big deal that's overlooked is centering your implant in the space. For example, a molar at the back, if you are off center or angled, it totally changes the emergence of your restoration. And so if you are eccentric from the middle of your restorative envelope, you'll have quite a close contact point on one tooth and then this massive overhang because your crown has to come out and reach the adjacent tooth mesially, for example, and that creates a higher chance of black triangles, more space underneath the restoration for food to get trapped. And again, we talked earlier, didn't we, that is not setting the most favourable conditions for that implant to be healthy in the long term.
Brilliant, brilliant. Thank you for that, Robbie. So, if some of our listeners are wanting to start on their implant journey, or suppose they've done a few courses and they've had the brief introduction to implants, and what sort of training pathway would you recommend for people who actually really want to place the implants and not just know? I mean, sadly, we see, people have gone on courses and then they haven't done enough implant placements per se, and they don't feel confident when they've come back to actually, start placing implants. So, what advice would you have for our, dentists who are wanting to start on their journey or, progress on their journey?
Yeah. Well, we're lucky in the UK now because there are many excellent courses, out there, and sometimes the difficulty is choosing or even recommending one. But I suppose there are also some not very good courses out there, and they're again difficult to pick up on when you're looking at a prospectus and reading about it online. So it's really challenging. I think word of mouth is always the best with courses in dentistry, and people who have been on the courses or know the people running them. I think that's an important thing, is looking at who's running it and reading up a bit about them. What's their credentials? Do they have a background in education or any qualifications in that? Because I think someone could be a great surgeon but not a very good teacher. And so that experience, and also how much have they done themselves? You'd be amazed at how many people start trying to teach when actually they haven't got a massive amount of experience themselves in what it is they're trying to teach other people. So going on a course by somebody who is credible, if it can be a recommendation, even better, because you've seen that someone's come through it, and what better recommendation is there than that? I think for people who haven't done any courses yet and are wanting to get into them, I think particularly with implants, trying to do a course where you get some degree of hands-on experience is important. I think a theoretical course is not enough, because you will come out of it having a decent amount of knowledge probably, but I just don't think you'll have the confidence, and you won't have the competence to then go and start placing implants. So a course that provides patients, or that you can take your own patients to, is great, and ideally one that's got a guaranteed, inverted commas, number of implants that you're going to do, because again, if you just do one or two with your hand being held, it's not going to give you enough confidence. Beyond that then, and probably most importantly, because this is where you will learn the most and come on the most, is finding a mentor who's going to help you and come and mentor you in your practice or in their practice, however the relationship develops, to be there for your first 10, 20 cases, because that is not only essential, and actually I think from a medical, legal and litigation point of view, it is essential. There are guidelines out there now by CG Dent, I think, on implant mentoring that recommends 10 or 20 cases, I think it is, should be mentored for each stage of implant dentistry as you progress through the more complex procedures. But it's where you get your tips and tricks, and you figure out even just where to stand around the patient when you're placing, how to hold the implant drill, what types of guides are available. There's so many little, even just your incision in the mouth in a particular case, having someone there with the experience to teach you those things you won't get on a course, and that's where you will grow and develop the most. So having, even before you do a course, my opinion is find a mentor who is happy to hold your hand after it, because you've just said it yourself, people go on courses all of the time, come out and then never implement what they've learned, and they're expensive, it's a waste of money. I think find a mentor first, and be confident that you in your practice can implement, that you can come off that course and go and place implants, because getting set up in implant dentistry is expensive. Buying implants, buying implant kits, surgical kits, restorative kits, the implant motor if you don't have that already. So depending on where you're working, if that's already in your practice because someone's already doing it, perfect. And you might even have another mentor in your practice who's willing to take you through your first few cases, and that would be ideal. But if you own your own practice and you haven't got any of this stuff yet, it's a massive investment. And so I would have a plan to not just do the course, but what comes after it.
So finally, Robbie, I need to ask you, we all get stressed at work, and we all have different ways of managing that stress and how we cope with it. So can you share some tips? I mean, do you get stressed out, and how do you manage with it, and what advice would you give to some of our fellow clinicians who are facing a little bit of stress in their life? Maybe it's work related, maybe it's outside work, but generally the situation is stressful. So please share with us.
Yeah, I mean, 100%. No, I think everybody gets stressed, don't we? And it's a word we probably overuse these days, because a little bit of stress is normal and is healthy. And actually, I thrive on stress at times, in stressful situations. I'm one of those people who probably runs on it a little bit. My wife says that. But then I have also 1,000,000% felt overwhelmed and felt burnout and pushed things too far, taken on too much. And I think they're the times when you need to pay attention to what's going on in both how you're feeling, how your mental state is, how your relationships are with the people around you. And that is the key to me, I think, is having the support of family and friends around you who can call you out in those moments and say, I think you're taking on a bit too much at the moment. You don't quite seem yourself. You seem a bit short. You seem a bit tired all the time. You don't look great. Who'll give you the honest opinion you need to, because sometimes we totally lack perspective on our own situation, don't we? And we think we're doing fine, and actually you're not. And they're the moments where your health is the most important thing to you, because nothing else matters. That should come first, your health and your family, and that's way more important than a job. I love what I do. I'm lucky, and the downside of what I do and the sort of niche that I've carved for myself is that my treatments are getting more and more complex, more and more challenging. They're taking more and more planning. And yeah, you just said, do you get stressed? I had a full arch yesterday that was really narrow, atrophic maxilla, needed a unilateral sinus lift at the same time, and all this kind of stuff was going on. And that case has been on my mind for the last couple of weeks, and certainly the night before I sat and I spent an hour going through it on the scans. And that night, I was stressed going to bed, and the next day I was stressed, but actually it went really nicely. And after it, I was euphoric. It went great. And that for me is a manageable stress, because it's short-lived. I'm in control of it. It was one case. I only ever take on sort of one big case at a time. I booked the whole day for it. So I didn't, I managed the stress. And after it, we got the payoff, because the patient is overjoyed. I felt good about it. I felt good that I've achieved what I wanted to. And felt great after. And then importantly, again, how I managed my stress, once that had finished, I came home, phone goes away, and it's half term, I'm there with my kids and my family, and we have family time. And so it's literally like two lives. One moment I'm doing a full arch and there's flaps up and bone and drilling and all this kind of stuff, and then an hour later I might be at home playing with the kids. But it's important for me that you do zone life like that, and that you give priority to everything. It has its time. It needs implant dentistry. I think people misunderstand or underestimate how much time is taken up of your life around sitting there and doing it. There is so much planning that goes into it, particularly for difficult cases. The letters we have to write for patients for informed consent these days is massive, and then the just the difficulty and the complexity of doing it. It takes up a huge amount of time, and that adds a degree of stress, and again eats into home life. And you've got to keep an eye on how much you let it eat into home life, so it doesn't cause that burnout like described. I've had that in the past. I've gone too far one way, and I've stopped, reflected, changed my practice, changed my work days. I think you've got to take action to address those issues when they become apparent, because if you ignore them for long enough, something will give.
So finally, Robbie, tell us which practices is it that you work at? How can people get in touch with you? Do you have an Instagram, a website? If people want to refer a patient to you, what's the best way to do that?
Yeah, I suppose first easiest point of contact to get me, anyone who doesn't know me, is probably my Instagram is dr.robbie.williams. And I post cases now and then when I get a chance, when I have the time. Try and keep in touch with people. And I love Instagram for that kind of stuff. I think you learn loads from other people, and it's a great platform for dentists, especially these days, to communicate with each other and share cases. So get in touch with me through Instagram. And on there is links to the two practices that I work at. So I'm 50% hospital consultant in oral surgery in Arrow Park, and then I work 50% out in private practice in two really nice practices. One is Sunlight Dental Practice on the Wirral, and one is the Abbey by Duthie Dental in South Liverpool. So kind of northwest area, and yeah, more than happy to take referrals from people, and thank you very much for all of your kind referrals over the years.
You're more than welcome. Robbie, it's been a pleasure. Thank you for sharing your stories with us. Thank you for your guidance. I'm sure this will benefit all our listeners. Thank you again.
My pleasure, Pradeep. Thanks for inviting me.